afternoon, good evening to you. I know you're coming from different time zones. We've got a lot from Geneva. In fact, as Loyce knows, the intergovernmental negotiating body is meeting today, and I know that several of the key people on those negotiations, it's about past 7 Geneva time, are actually here with us through live stream. It's my really great pleasure to introduce Loyce Pace, the Assistant Secretary for Global Affairs at HHS. There's a lot of things I could say about her, but I think that we're going to be starting with a little bit about her career and vision. So I think I only want to say this. She is my hero. She has been for a long, long time, and everywhere I go around the world, whether it's to the UN or to the World Health Organization or the bank or G7, she is just held in just enormous esteem and regard. The service that she's given the public, the global public, the American public, we really don't stop enough and just say thank you. So thank you. She's had an amazing career, not just as the Assistant Secretary, reporting directly to the Secretary and responsible for the international agenda from the G7, the G20, the UN General Assembly, the World Health Assembly. But before that, she's been a powerful force in community-based organizations and grassroots action in Africa and Asia, calling for person-centered access to health. So today we're going to have a little bit of a fireside conversation. It's really about a what's what in global health. So let me just tell you what I hope to cover in about 40 minutes, because Loyce has to leave. But I'm going to start with your career and your vision. I'm going to move on to the World Health Organization and the reform agenda and the US role in that. I'm going to then look at global health law and governance with the IHR reform and the pandemic agreement, and then major global health law reforms for the future, sharing of scientific information, equity, finance, compliance, implementation, and accountability. And then I'll finish off with just a small little thing like sovereignty and the future of multilateralism. So if you get through all of that, we'll do it in the speed version and see us get through as much as we possibly can. We also want to leave time for question and answer from the students, the wider audience, and we're all going to take some live stream questions if we can. Let's just start with the HHS Office of Global Affairs, and you work at the G7, G20, UNGA, WHA, things like that. Tell me a little bit about that.
Sure, no problem. Good afternoon or good evening for folks who are watching from afar. And first off, thank you, Larry, for those very kind words. I can't get emotional at the top of this, but that was unexpected for you to offer that gratitude and support. I right back at you, frankly, because we were talking before we started just about how hard and heavy the work we do is. And I don't know how many people in the room are engaged in this every day outside of studies, but public health is work, actually, and public health policy. I won't compare it to public health services, but it's a lot of work too, in ways that people don't always see. And so I just want to extend my thanks to you personally, but also to the work that happens with O'Neill and at Georgetown with people in the room and online to just try and advance this really important goal, not just in the US, but around the world. And so that's our that's our mandate at the Office of Global Affairs as well. A lot of people don't realize there's sort of this island of diplomacy that sits within the Department of Health. We obviously care about and work in service to the health and wellness of Americans, but we don't believe that work stops at our borders. And in fact, you have agencies within our Department of Health, like our Centers for Disease Control and Prevention, or our National Institute of Health, even our FDA, and other outfits that actually have a global footprint. They have staff on the ground, they have initiatives that they advance with partner countries. And that's on purpose. It's because we just believe, well, US experts don't have all the answers, go figure, right? And we can actually get more done in service to Americans in the world in partnership with others. But importantly, also, we are just all tackling some of the same problems, but in different ways. And there are plenty of ways that we at home can learn from folks abroad. I know I got into this business focused mainly in non-communicable diseases. And it was really important for me to be able to liaise with experts and actors in Africa, in Asia, and Latin America, and ask, well, as you're trying to bring down these rates of cancer, morbidity or mortality, how are you actually doing that? And specifically, how are you doing it with populations and communities who have these exacerbated rates among them? So that's really one of the reasons why I was really excited to take on this role and really honored to be offered this position, because that's what we're doing at HHS largely, is really asking those questions about how we can do more for ourselves in partnership with others around the world. And then, if we're getting it right, actually also help others, right? Assist other countries and governments with some of the questions they might have about how we're doing it in a way that could be helpful to them.
Yeah, and you mentioned to me when we talked yesterday about the importance of, interagency coordination and the State Department's Bureau of Global Health Security and Diplomacy. How does that fit into your work?
I think it fits in really well. So, you have a shop like the Office of Global Affairs and HHS broadly, which has been doing this sort of technical assistance or other types of exchanges, diplomatic exchanges for decades, particularly in the health space, right? And you obviously, our State Department is the lead on diplomacy at large, but they recognize the importance and the value of lifting up health as a political priority. I think we and they actually did that most glaringly with HIV and the PEPFAR program, but with everything that we've endured with COVID and just broadly with people are really coming to realize about global health and global health security, they know that they need to sustain this political attention and momentum in foreign policy channels too. So in addition to our health secretary, Secretary Becerra, being able to meet with his counterparts or with Dr. Tedros at WHO about these priorities, you have Secretary Blinken, who's able to speak to other state secretaries, right, or foreign ministers about some of the same things. And so it's really a both and strategy that we have across the US government, and it's not to exclude important work of implementing agencies like USAID and CDC, or even the work of the White House and NSC.
Liz, in terms of your deeper career, your community-based grassroots action, particularly in Africa and Asia, how does that influence your vision today?
One of the things I learned early on was the power of partnerships. And I mean, frankly, I came into this space volunteering at health fairs in the city where I was raised in Los Angeles. And it involved me doing various, after school fairs to talk about the dangers of smoking. It involved me going to church fairs or other faith communities to talk about the importance of screening or even diet and exercise. So it was really, I think a lot of times in public health, we find ourselves teaching others how to do those things or funding that work from afar, but I was doing it at home. Yeah. And I was recruiting other volunteers like me, right? And eventually I stumbled into, thank goodness, a paid position, because people should be paid for that work, to be clear. And was able to do that in my community and just increasingly felt and even saw how connected that work was in South Central Los Angeles, right? To other cities around the country, but frankly, to other cities around the world. So even one of the programs that we would advance at home, and this is dating myself, but we have this Promotoras program that we had learned from people who had worked in Mexico and otherwise on the border. And it was really, again, just an eye-opening experience for me to say, okay, that makes sense, right? We have all these answers about or questions about how we could better approach, particularly Spanish-speaking communities in Los Angeles. Let's learn from these communities where from which they've arrived, right? Many of these families, whether it's decades back or days ago. And so that was a really important lesson learned to me as well. It's just again this power and importance of exchange, and that's why it feels like such a great fit doing what I'm trying to do now.
Yeah, and one of the things I love about your background is that, I've always thought, I go back way to the beginnings of the AIDS pandemic, Tony Fauci, and I've always thought that age changed the world. And the main lesson that AIDS taught me was that if you really want fundamental change, bottom-up social mobilization is the way to do it. And you that's your background.
Yeah, absolutely. And every role that I've had, that's been the starting point, right? So, whether you're mobilizing the cancer community in South Africa and Nigeria and Thailand and Philippines, or you're working with people living with HIV or TB or otherwise, it just has to start with people. The people know what they need, right? They have these very clear experiences, and it's people at the community level and people who are really trying to change the systems and shift the power. And so that was also an important lesson for me, is that we're not just talking about small change. People can be a part of big change, fundamental change.
Yeah. And I think that's really important for our students in particular. So let's transition to some of the substantive issues that really we're facing. And we'll start with the World Health Organization. Both of us work really closely with Tedros and WHO and the whole team there. And I know we have some WHO people listening in now. WHO, it's got so much that we always say that needs to change, but I wouldn't want to be in a world without WHO. So the US has been really an important driver of WHO reform. And let's talk a little bit about, what your vision is for WHO. I'll tease out things, but financing, efficiency, governance, transparency, accountability. Talk to me a little bit about your and the USG's position on strengthening WHO.
Well, I think you're right, Larry. If WHO didn't exist, we'd have to create it.
Yeah.
Right? And in its 75-year history, WHO has done so much for the world, notably smallpox eradication, right? Thanks goodness. Let alone all the work they do today. Just take global health emergencies and how many global health emergencies we have the world over at any one time, right? And whether that's an outbreak here or there that those teams are trying to address or respond to, and they're not just in the global but the country offices, or unfortunately floods or conflict or other crises that come up that have really important health considerations. And so WHO does a lot. They do a lot more than people realize, right? And oftentimes it's like with our CDC, right? The success doesn't make headlines, right? If you're actually doing your job well and successful at what you do,
exactly,
people don't know.
It's only when you screw up.
Often, unfortunately.
Yeah.
But and it's not just the sort of the frontline stuff, it's the setting the standards and making sure countries have guidance with regards to how they approach health priorities, right?
Technical assistance.
Exactly. So
So
all that stuff, WHO, we need WHO for, and we need WHO to keep doing. And what I appreciate within the ranks of WHO, and particularly of their leadership, is that Dr. Tedros was very clear on the need for WHO, obviously, but the need for there to be a strong WHO.
Yeah.
And he came in on day one as part of his initial term to really say, okay, we've got to transform WHO in a way that makes it fit for purpose, because the world is changing around us, and this was pre-COVID, right? So let alone now with COVID in our wake, it's very clear to all of us, all of the work WHO must and should do to ensure that it's keeping pace with the changes of the world. And so, like you mentioned, some of that is, some people really enjoy this, some people call it boring, right? But some of that is really looking at how they're spending their money, right? And ensuring it's tied to very clear strategic priorities and objectives, what we call their general program of work, right? Some of that is very discrete and specific around really important issues that have emerged in recent years, like preventing and responding to sexual exploitation and abuse and harassment. And so they have, a whole list of reforms that I think even they had identified, but importantly, we were able to come to agreement on as member states and WHO leadership. And you're right, the US was largely pushing that with other countries saying, hey, we want to support you, but here's how we can all be better together. And some of these reforms were even on member states to implement too, honestly. We all show up at World Health Assembly every year, well, maybe not all of us, thankfully. Be grateful you're not showing up at the circus every year. But the agenda items are just out of control in some cases for these so-called governance meetings. And there's no way for an organization or institution like WHO, with the limited human and financial resources they have, to meet these growing expectations that we all have of it. And so we have to sort of rein ourselves in to a degree, and make sure that we also are being fair to the staff in that building and really focusing on their highest and best use.
Yeah. What about WHO financing? Recently the Assembly decided to increase the assessed dues, the so-called mandatory dues. Is the US government been, what's our role in that?
Yeah, so there was a real, it was really important to a growing number of member states to put this on the agenda for WHO, recognizing this growing list of expectations that the world has of the institution. Mm-hmm. And the US wanted to be at the table for those discussions, but importantly wanted to ask some critical questions about what it would mean to increase the assessed contributions of WHO, and whether WHO could keep pace with these proposed reforms alongside that push for additional resources. And so their answer was yes, right? And we had a lot of conversations about how to be sure one tracked with the other. But at the end of the day, it is about making sure WHO has the support and capacity it requires to get the job done, to get the job that we require of it, right? Not just America, but member states all over the world. And it does require member states, really stepping up their game too and ensuring they're showing up to support WHO in this way. But it's an important, contract, that we have with one another, to say, well, we do have these expectations about how WHO can deliver, and we are willing to invest in WHO to the degree it is able to breathe into this moment.
And you've also supported governance reforms and transparency, accountability, in those areas.
Yeah, the US has a role on the WHO board, and I've been our alternative representative for the past couple of years. And in that body, we're able to have even more in-depth conversations about some of the challenges WHO faces and ways that we can, improve that work. And as you said, improve transparency, oversight, and accountability. One example of that has been the new standing committee for global health emergencies.
Yeah, that's right.
Very well. So just to give board members that much more kind of clarity and awareness of some of those tough decisions, right? And be a resource, frankly, to leadership when it comes to some of these really tough calls that have to be made quite quickly.
And you're gonna, span both New York and Geneva processes. And so recently in New York,
Yeah.
as you know, there was a political declaration on pandemic preparedness and prevention and response. And so how is the kind of coordination between New York and Geneva in your view, and can it be improved?
I think that the co-facilitators of the high-level meeting did a good job to understand the ongoing negotiations.
Yeah, I think so too.
Yes, and so they were very clear, that they didn't want to undermine or somehow get ahead of the process in Geneva, compared to what they were trying to accomplish in New York. I think it was an important marker that they set, at least to keep pandemic preparedness, prevention, response on the agenda. And I know that folks are interested in how that political momentum can be sustained, right? So coming back to, say, the role of a Department of State or even a White House, right? Versus what the Department of Health is doing. We can all agree that this work should absolutely continue in health channels, but in addition to that, what is the role of political actors in this space? And New York helps at least convene that conversation, if not directly answer that question.
Yeah.
I think there's still, a question mark around this, right? And I know that there are folks probably online, if not in the room, who are still trying to land this plane. I wonder how the negotiations will help us do that as well. But ideally, look, people say all the time, we just want to get out of this crisis complacency pendulum swing. And, again, one way forward that people have envisioned is making sure that it's not just the health actors or leaders ringing the bell, but rather we are joined by a chorus, or if you want to keep with the analogy, sort of an orchestra of musicians.
Yeah, and there's a lot of talk in global health about World Health Assembly, mostly health ministers, and then government and high level political support, which hopefully New York can bring.
If not G7, G20, and other spaces where
exactly
we have these conversations.
Exactly. So WHO reform, I want to now dig in a little bit about global health law and governance, the IHR and the pandemic agreement. I want to begin by saying something that most people don't understand, which is that the US has been a really constructive actor in all of this. And when I talk behind the scenes in Geneva, I hear that all the time. It's not publicly understood, because the US often gets painted with this brush of being obstructionist, and it's far from that. So we'll begin with the IHR. So IHR reform probably wouldn't have happened but for USG. So you made a number of really important proposals, and then a lot of other countries, including food blocks in Africa and in India, came on board as well. Some of them were asking for different things, but many similar and harmonious things. I had the privilege of being on the IHR review committee, so we reviewed all of that. Talk a little bit about what you see the US vision for improved IHR, and if you want, you can talk about some of the gaps in the regulations during the COVID-19 pandemic.
Thanks for that question. I have to stop here and acknowledge the work of people who came before me, because like you said, this has been, a while in the making, and now we're at the point where we are negotiating targeted amendments to the international health regulations. Whether or not that's a list of 300 or the original 1314. But there were people, and I will be explicit, career US staff who saw the opportunity here and who really helped shape and frame this work in a way that, as you said, has been incredibly constructive. And so I'm really grateful to the foresight that they had and the ways that they put this in front of leadership even before I got here, right?
Yeah.
We were happy to take this on and even elevate it even further, right? It's something that was approved in my tenure, and we're grateful that WHO and its member states really took this up. It wasn't without some, conversations behind the scenes to help people understand what we envisioned. But the whole point of it was to say, look, we have this existing framework that's supposed to tell us what to do when that bell is rung, right? And we've only modified it a couple times.
Yeah,
since
last
its
time
existence,
during
right?
after SARS.
Exactly, 20 or so years ago.
Yeah.
So, there's some folks that might ask, well, if it didn't work, then why are we bothering? Well, it actually did work, because if we didn't have anything at all, it probably could have gone worse, right?
Sure.
It's hard to, the COVID was hard and it has been tough, and it could have been worse, without having this framework whereby we would understand what's happening in different countries, how it was evolving in different places, how we could even then exchange that data ahead. Whose job it is to actually pick up the phone or send the email and make sure that someone else knows what's going on. So there's a lot of stuff that was in place that was really helpful. Now, the problem between having something that's 20 years old versus having something fit for today is, one, our communications has really, really changed in that span. And that's something that we recognize. The way that information moves in the world now is very different today. And we felt and saw those cracks during COVID and wanted to try and solve for those. There's also just this question or concern we had about how we trigger certain actions, right? You receive information, and then what does one do with that information, whether it's WHO, whether it's another country, both and so what we've been trying to do with these adjustments or changes is answer those outstanding questions, right? And really be more clear about what requirements WHO has or what needs we all have around the information we receive. And then again, what we do with the information, one, or in the absence of information, right? What happens if we're not really getting information from country X, Y, or Z, but we're seeing it on social media, right? Something's
big issue.
Exactly, something's happening. Well, then there has to be some sort of verification or other process whereby WHO and other countries can act accordingly, in the absence of something more formal or official. So those are the things we're trying to work through. And it's not straightforward, but I give credit to a lot of governments and their representatives around the table who are trying to work through various proposals. And there's some banner proposals that the US really wants to see, in addition to this question of how information flows, which is related to how we even grade or tier various alerts, which you're very familiar with.
Yeah, so just for the audience, currently there's a public health emergency of international concern. Some countries, I don't think the US is one of the kind of intermediate levels. So what you've basically been focusing on, I think rightly so, is how do we detect accurately and rapidly a novel outbreak? And then what do we do with that information? And what roles and responsibilities do people have to try to contain it as quickly as possible? And clearly that was a big problem during the outbreak of SARS-CoV-2. And even today, we don't really know the full story about the origins and probably a zoonotic spillover, many or several, but we don't know. the other issues that travel restrictions, a lot of people talk about those, and particularly against Africa. And then finally, and then there's a lot of political dimensions to that. So you might want to just say a little bit about travel, and then I want to get finished with kind of looking at the US proposal for implementation committees. Which actually I think is not that far different from what the African Union has put forward for compliance committees. So take us through that.
Yeah, I'll try. I'll do my best. So, just coming back to why the IHRs are important and why changes to the IHRs are important. And Dr. Tedros talks about this well. A big objective and a primary goal of the IHRs obviously is to sort of stop an outbreak where it starts and before it becomes a full-blown public health emergency or international concern. But also to ensure that countries aren't taking measures that are going to be harmful for their communities or for societies, like travel or trade restrictions. And so I think at a basic level, it's just really important, especially for those of us in the public health community, but I think overall that we are really doing what we can in a public health space to prevent those types of actions from being taken, right? You never want to be in a position where you're having a political conversation about a public health crisis, really. Ultimately, unfortunately, we do all the time. It's a part of the course these days. But ideally, you are able to actually use public health measures to solve the problem full stop. And so that's our goal with the IHRs and some of the changes that we're proposing when it comes to the specifics around the committee and sort of the related capacity building components. We're having really healthy and important discussions with other countries about what it looks like not only to have this sort of these requirements in place for countries to report or put in place all of these different structural pieces, but rather to also recognize that not all countries are ready to respond. And there are plenty of countries who are saying, we need help getting there. We need time to get there. And there are ways the US has worked bilaterally with a lot of these countries. There are ways that we've worked multilaterally with these countries, such as through the Global Health Security Agenda.
Or PEPFAR.
Or through PEPFAR, thank you very much, right? In ways that our existing programs have been leveraged. But it's just a really important consideration of these conversations to not only have this sort of punitive or sort of accountability lens, but to have a clear capacity and more supportive, incentivizing ways that we're bringing people to the table.
So one of the big issues in the IHR for all of you is core health system capacities, IHR capacities. Part of that is how do we help low and middle income countries to develop robust and sustainable capacities. Part of it is how we evaluate and monitor those capacities. Do you want to say anything about those areas?
That they're important. No, I mean, I think you said it, and I think one of the points that we get into, not just around the international health regulations, but in other negotiations, is sort of this. I guess I'll call it a package of benefits or package of activities, right? Where that includes some of these important capacity building components, recognizing that it's so much of the conversation can be reduced to data and samples and products. And I think we forget about the enabling environment for those things.
Exactly.
And I feel like that's what you're getting at.
It's exactly what I'm getting at. Surveillance capacities, laboratory capacities, response capacities, good laws, global health, domestic health laws that kind of make that possible.
And I have to thank Georgetown for supporting some of that work. I hope I'm able to do that.
And that's in the rooms.
People forget about, and in a lot of countries, there were plenty of aha moments during COVID and other moments. But one huge lesson was, oh gosh, we have to think about the legalities of what we're doing.
And you need to have strong laws, and also, even for things we're about to talk about in terms of developing local capacities for manufacturing of vaccines and drugs, you need good regulatory authorities like equivalents of the FDA in those countries. So I think the IHR may be making more progress in Geneva than maybe the pandemic agreement. We mentioned earlier the 7th meeting of the Intergovernmental Negotiating Body is going on in Geneva as we speak. Right now, I'm in close touch with Precious Matsuso, who's fantastic. Yeah. So rather than I think I'm going to talk about specific issues related both to the IHR, but mainly to the pandemic agreement. And I'm going to start with scientific sharing. Because it's important in its own right, but also because it's been linked in some people's minds with equity. So scientific, I know this is a big issue with NIH. We work closely with NIH and FNIH on this. We just put out a report for WHO on this. But it's basically open and rapid sharing of pathogen samples, genomic sequencing data, more open access, a lot of exchange of research. And the US has been pushing for this, both in the IHR and in the pandemic agreement. I'm not going to just talk very briefly, because we've only got less than 10 minutes, about the importance of scientific sharing. Then I'm going to move us to what we all know is the heart of this, which is health equity.
Yeah.
Both domestically and globally.
Yeah, no, that's it's kind of hard to talk about this in its own right, but you're right. It's really important to the US and for plenty of other countries that we don't hinder the open channels that we have, frankly, around scientific exchange, and that we can open those channels even further, right? I mean, we benefited so much from that type of exchange during COVID, but for all kinds of things, for HIV, for malaria, and beyond. And so the work towards the agreements, and as well as in NIHRs, is really focused on how we can share data, samples, everything in between that is important for scientific innovation. And then recognizing that those innovations are key too, right? And really, we really need to keep in mind access to those innovations.
So our goal is, whenever we have a novel threat, we want to ramp up research and development and deliver countermeasures, diagnostics, PPE, therapeutics, and vaccines as quick as possible. But then, and this is very important to low and middle income countries, but it's also important to us, that we have an equitable sharing and allocation of those. And that's been really animating, in my view, the Geneva negotiations because of what we saw during COVID.
Absolutely.
Just the shocking disparities. Frankly, it happened in the United States as well, and Europe and other places, based upon race and socioeconomic disadvantage and a whole range of other issues with African Americans, Native Americans, others dying at much higher rates than other groups. So how can we get to equity? I know this is a big issue. I mean, I'm just going to list them. I was going to talk about them separately, but I'll just list them and just have you kind of reflect on them. I mean, one, of course, is the traditional idea of donations. But I think, it's fair to say that a lot of Africa and other countries think that hasn't really worked the way that's fair and robust. Then there are intellectual property rights waivers, which President Biden was, really out front on with COVID vaccines, but never really got buy-in in Europe and through the World Trade Organization. And then finally, and maybe most importantly, this idea of technology transfer, so that we can have diversified manufacturing. And so, low and middle income countries don't have to wait for the donations, they can manufacture the products themselves.
Yeah.
And the WHO messenger RNA technology hubs. Now I know that's a big mouthful to talk about, but can you reflect on what you see as the problems, sticking points in the negotiations, but also which of these models or all of these models have the most potential and how we can get there?
Well, this is the issue, right?
Yeah.
And it's one of the reasons why we're all at this table anyway,
Yeah.
because, otherwise we can just rely on the IHRs to fix all the things, but
Yeah.
that this is an area the IHRs just don't cover, right? How we can ensure that we do even better than what we did under COVID. And, the US was proud to share vaccines with the world when we were able to do that, but you're right, it was not enough or fast enough for plenty of countries and communities, and we have to be honest about that. We had this sort of sharing, spending, scaling approach or triad, and I want to credit Dr. Hilary Marston, who's now at our FDA as our CMO, with that framework that has stuck with me for the past couple of years. But it was purposely a three-legged stool, because it doesn't just come down to what you can donate, and it's great that countries like the US were willing and able to share other surplus or otherwise or directly. But it was also important for us to provide capital, funding to initiatives like COVAX, right? To be able to purchase and to allow them to take our place in line, places like the AU to take our place in line, right? So that they could purchase. And so keeping that spending in mind is critical, particularly when it comes to also the structure or enabling environment for some of these products. It's not just getting the stuff to people, it's making sure, or to countries, it's making sure that
the delivery
exactly, right?
Just as important.
Right. And Dr. Okija talks about ports to arms, right? And just making sure that we can actually reach folks. But this other important aspect of scale is critical, because the supply chain, it really broke down, not just in health and medicine, but across the board. And I'm not an economist, to be clear, but it was very clear that we needed to diversify our supply chain and our medical supply chain to a great degree, and it really lends itself to the diversification of regionalization of medical manufacturing. Now, there are plenty of questions and concerns about not just tech transfer, right, but sustainability, what's going to be able to keep these efforts warm over time. And, hopefully people know that by the US being at this table, that we are supportive of diversified manufacturing. And we think it's important to link all these things together, as you have, right? To talk about it in the context of R&D, of voluntary tech transfer under mutually agreed terms on, with regards to supply chain and how products move around the world. It's I think where our challenge is when we try to have these conversations in silos, when they're so interconnected.
Yeah, I often say with all of these mechanisms, and they say, which one do you want? We want them all.
It has to be, actually really
because we're never going to get anywhere close to equity without them all.
Yeah, well, it's one of the reasons the US has invested in the pipeline, right? We've invested in research to response and the pieces in between.
One of the models that is that is of great interest in terms of equity in Geneva is so-called access and benefit sharing, the ABS models, which is based, I guess, originally on the pandemic influenza preparedness framework, the PIP framework. But there's a lot of conversation. It's a controversial topic. I mean, even in civil society, some in civil society really want it badly, and others don't want it at all. And there, from a legal point of view, there's also the Nagoya Protocol that has countries owning this information and wanting and sharing it in conjunction with benefits. And Steve Solomon at WHO, who's their legal officer, often tells me, you know, this is not, it shouldn't be, and it isn't transactional, that it should be a multilateral form. So what's, you know, how are you thinking about ABS systems as part of the possible way forward to achieve greater forms of equity?
I mean, it's, you know, I appreciate you flagging something like the PIP framework, and I can see how people are drawing these connections, but you're right, it's I think many people will say apples and oranges, right? It's still in the fruits, but you know, there's some differences there. Importantly, we, for example, didn't have available products for COVID in the way that would have worked, or the way that PIP was designed, and there wasn't available, you know, the way that a market would have been defined. I think people would have questions about how all of these things are sort of mapped to what's existing, but it is important to think, okay, well, what are some lessons we learned from the standing up of those structures, even if those, you know, something like the PIP hasn't even been tested necessarily.
No, it hasn't.
So we don't actually know it.
So far, we haven't had pandemic influenza.
But this, you know, we do have to, as you're saying, acknowledge that we need both data, pathogens, samples, and medical products and innovations to be readily available. And the good news is that the US, I can't speak for other countries, but I can say for sure with certainty how hard we're looking at this problem, and how hard it is to work through the hard problem, right? We are having conversations you can imagine, not just, you know, between the health department and the state department and the White House, but you know, you have commerce, we have so many USTR and so many other parts of the US government to
Congress.
less I forget. And so that, you know, to me, that's a good thing, right? Like people care enough and are focused enough on this as, again, a major solution, if not the solution, to get us across this finish line. And that's what we're gonna need. We need all hands on deck.
We do. We're kind of running out of time before question and answer. So I was going to talk about finance, but we can have that in question and answer. I thought the last question I would ask you before we turn it over to our audience is really about things that sovereignty and the future of multilateralism. Will it work? What are the threats to multilateralism? How do you connect the dots about all those threats and dysfunctional noise that we're hearing in this space?
So for folks who don't know, which is hard not to know when you look at my social media feed, for example, there are a lot of questions and concerns about what's happening in these negotiations. And I think a lot of us were just really surprised to see that pop up, you know? We were just sitting here as, you know, folks who were just like toiling away in Geneva.
Or just trying to make the world a little safer.
Right. And sometimes you're doing it at 3, 4 a.m. from Washington, right? It's not glamorous and certainly not nefarious. But unfortunately, you know, there's a lot out there that is not accurate about what it is that's happening. So hopefully people are gleaning more from this conversation, but and, you know, I want to appreciate that folks, I mean, look, again, like folks are paying attention, great. We want people paying attention to pandemics and pandemic preparedness and supportive of these small or large efforts that we are undertaking to try and make the world safer, to make America safer, right? What we also want them to understand is that it has nothing to do with taking away anyone's rights, right? Individual or otherwise. And it's not just us being clear about that as US officials, WHO is clear about that. It's in their constitution that it's all in countries, as much as WHO would love for countries to do everything that they ask, I think we're pretty clear that that our governments follow WHO guidance.
Human rights is a very important principle in
Absolutely.
the IHR and the pandemic.
Absolutely, and so the institution and what it stands for is very clear that these are efforts and that will yield, a roadmap and recommendations for countries. And it is up to countries to take those actions under account and or to do so against or aligned with their own national priorities.
Yeah, and we need to be crystal clear. I mean, there's nothing in any of these Geneva negotiations that will prevent the US or the UK or South Africa from taking whatever domestic health policy decisions that they want to take. I think that's often misunderstood.
Yeah, it is.
Yeah. So I could talk to you for hours, and I hope we're planning a lunch, so we will.
Yeah.
But I wanted to open it up to our students and to our wider audience here. And then, Ali, did you want to kind of run this part of the show?
Yeah, we'll have Sophie go to anybody that has a question that I can call on. Also, if you just want to raise your hand if you have a question, and I will coordinate.
Who's gonna go first?
I know several people here who are definitely not shy.
Yes, and I know our students in particular. Okay, we've got a few.
That's
All right, good afternoon, good evening. My name is Kendall Martinez Wright. I am from Treatment Action Group, which is a nonprofit public health organization based out of New York City. My question for you, Loyce, is we already know also about tuberculosis and the high-level meeting on TV. Given the recent news out of New York, going to the domestic side, what are some things that we should be prepared in terms of advocacy as well as really pushing the narrative that TB is still currently the leading causes of death globally? Thank you.
Can we take one by one? Okay, no problem.
Yeah.
Thank you for this question, because when Larry asked about the PPPR high level meeting, I was really wanting to bring in the other two high level meetings that we had. And one of the comments I was making that week in New York was, look, this is about health, right? This is about how we lift all boats in health. I think those of us who are sort of pan health actors in our community really see TB as a major global health security issue, frankly, right? Let alone as a major health issue. And so I'm really happy that we were able to keep TB at the top of the agenda that week and not have it be sort of drowned out by the conversation around pandemics alone, and that we were able to importantly connect those conversations. And then let's not forget about the high level meeting on UHC, which is sort of the boat in which everyone rides ideally, the sort of focus on access and even equity as part of our agenda. But Larry and I were even talking a bit beforehand about how so much of the conversation importantly has been about COVID or, Marburg, Mpox, other things the past few years. And yet we still have a crisis. We still have a crisis in this country, frankly, when it comes to issues like HIV, like TB, and around the world with malaria. I'm filling all of the blanks. And so we cannot leave our siblings behind in this space as we're having these negotiations. And in fact, these other health priorities are top of mind for negotiators in Geneva and for those of us who are showing up in other capitals to have these discussions.
Yeah, if we had time, Loyce and I were talking earlier on that when we talked about equity, we wanted to broaden it out to, broader forms of equity, and not just for pandemics, but also NCDs and, tobacco.
SRHR.
Yeah, exactly. Do you want to, go on, guys.
Yes, I'm Medina from Ghana. I just want to understand all this equity logistics at the end of the day, the World Trade Organization, are they part of these negotiations? Because it all comes back to trade. How will somebody send medicines from US to Ghana if trade barriers are not broken or something? I just want to understand.
Yeah, it's a very fair question, right? And it's definitely outside of my lane. This is one of the challenges we have in probably in development overall, right? Is we're so siloed. But no, is the direct answer to your question. WTO is not at the table for these WHO conversations. That's by design, right? Just like we are not a part of their conversations at the WTO. Now, are we clear that we have a relationship to one another? Sure. And I think it is up to member states that are engaging in both of those conversations to try to be mindful of those connections and to perhaps build bridges between them. But unfortunately, we are, unable to get into those areas as part of the conversations that we're having. It's one of the reasons why we talk about the importance of thinking not just about some of the issues that fall squarely into the lane of the World Trade Organization, but we're also talking about investments in those manufacturing facilities that are able to, for example, receive, say, government-owned technologies, through the Medicines Patents Pool or directly from NIH. I just came back from Brazil and also before then from India, where NIH had shared its technology so that companies in both of those countries could manufacture dengue vaccines, which we know the world needs given how things are moving or trending with that disease. And so it's still possible, even in the absence of negotiations either in WTO or WHO, some of this work continues to happen, but this is why we are trying to be as creative as possible, I think, as part of these conversations, and as comprehensive as possible, and not only thinking about one part of the solution.
Yeah, that's a really important point, and thank you for asking that, Fatima. One could talk about the synergies between WTO and WHO, but there's also so many other agencies, Gavi and SEPI, but I'm having in mind the World Bank and the pandemic fund and how that fits in. And then even broadening the lens even more, and it's certainly a big issue which we didn't discuss in Geneva, is the One Health approach. With food, animals, human health, and how that will fit in, if at all, in the negotiations on the pandemic agreement.
Yeah, if I can sneak in one comment in response to that, Larry. I mean, look, we started this conversation talking about people and how, I would say this throughout my career, people are whole people. They're not these body parts or just conditions, right? And it's when you start with people, you really appreciate the One Health agenda and approach, right? Or the connections between all these things, right? Social determinants and health outcomes, and it's obvious, but we've just spliced it in such a way. And it's really kind of hard sometimes bringing it together across all these silos. But I have to say that one of our goals as US government for the pandemic agreement is to have a channel or avenue whereby we're able to focus on something like One Health, because again, it's not really a part of these existing frameworks. And so if we can achieve things not just like equitable access to countermeasures, but also a more integrated framework or approach to some of this, including environmental, human, and animal considerations, I think we could go farther.
Yeah, certainly been a lot of proposals for that. It's, when I was talking to a lot of attachés in Geneva, basically the dynamic was, well, we all know we have to do this. Question is how do you get it done, particularly in the legal framework.
Sure.
So in the back.
Hi, I'm Oliver Thompson. I'm here in my second week at Georgetown as the Managing Director of the new Global Health Institute. And I wanted to ask, you started the presentation talking about the centrality of community leadership and community ownership and movement in your work, and that very much resonates with me. And I think key asset for that to be a success is trust, which hasn't come up very much here today. But I think I spent the last 10 years living in Sierra Leone and in Johannesburg and other parts of sub-Saharan Africa, and I would say my experience is that there's very high levels of mistrust between particularly young people in the global south, frontline health workers in the global south, and institutions and governments of the global north and international agencies. A disproportionate amount of distrust. You know, people are right to be sometimes skeptical. There are mixed motives, but the levels of distrust, I think, are astonishing. And I see that as potentially a very big risk for any of these things, be it samples or, you know, regulations or vaccines. None of them will be very useful without that. And I guess I wanted to ask the US government's approach to trying to restore or build trust with young people and health workers in the global south, and is it enough of a priority, but also enough of a focus? Because I think there's consensus this is important. But yet when we leave the room, you know, who is the Undersecretary for Trust? Where's the budget line for trust? Who's working on it? So I was just wondering on your thoughts, and it is work being done in it at the moment.
Yeah. I really like this question. I think I'll just say no. Unofficial position, right? It's not enough because there's still this gap, right? And what I'm gathering from what you're saying is we need to lead with it more and really start the conversation with that. I think where we have been really focused on trust has even frankly been at the institutional or government level, because I think we have to be honest about just that. I mean, yes, young people like really on the front lines, and also there are other countries who were very skeptical of the US and remain somewhat skeptical of the US even up till today. There's obvious skepticism, you know, between countries and WHO potentially, right? Or actors within those countries, policymakers within those countries and WHO. And so I think we've been hyper focused on building or rebuilding trust at that level, and surely are investing in other ways outside of policy settings and more through our programs at the community level, right? But bringing those together will be important, and I think that's why it's valuable. It's incredibly important for us to have community and civil society stakeholders at the table for these conversations, because then they're keeping us honest, right? And really saying, wait, you're saying all these things, but what we're seeing and hearing is that. And importantly, they could, if they so choose, serve as messengers, right? And kind of break down all of the stuff that happens in the halls of Washington, Geneva, and New York. Should all that work be happening solely in those capitals? No. Again, to be clear, they should be happening in Addis and Brasilia and elsewhere. What I will take away from your question is the importance and need to make that link even stronger. So thank you again.
Yeah, and of course, it's even broader than that, because it's certainly a distrust between lower and middle income countries and higher income countries. But you have a lot of distrust of institutions and science and public health writ large. Here in the United States, globally, WHO feels it. CDC, certainly, we were talking about Rochelle Walensky and others, Tony Fauci, who's here at Georgetown. These are really deep questions about the public's faith in science and in public health officials, global health officials, institutions. And we need that desperately.
Yeah.
Really.
Well, and it's scary how close it is, right? Because for a minute, I was in the COVID board, as I think you know, during the transition, and all of us were really tracking this disconnect between sort of the national or federal system and health institutions and the public. But what we also saw, right, was even this conflict or even assault on local health officials. And I think that's what got really scary, because, that's where we think the trust is, right? And yet, when that was broken, I think that was a really scary sign of how much work we need to do. And again, that's just within our borders, let alone, how our work or our presence is being received in other places.
Yeah, and we were talking before just how difficult it is to work in the public
Yeah.
health and global health space. And, if you think that, a local health officer is concerned about her career or even her safety, that's not good.
So,
Okay, we have just a few minutes left, so excuse my voice. I think we're gonna take one question from online to give equal attention to our online audience. And I know Larry had mentioned wanting to talk a little bit about financing, so we have Katri Bertram online who has asked. The WHO's role is to lead and coordinate in global health. It's currently not set up and funded to do this. What do you think needs to change? And before you answer, I just want to share, Kai's asked me to share with the group HHS's Twitter handles. If anybody is tweeting, we have HHS_global and HHS_ASGA. So that's HHS_global and HHS_ASGA.
Yeah, that's the world we live in.
I should just walk around with that. Well, thanks to Katri for that question. And yeah, I mean, look, the WHO needs to be set up for success. And it's one of the reasons why we sat around the table and we talked about and decided on the need for increasing assessed contributions. It's another reason why we sat around the table and talked about how their work could be, or resources could be reorganized and better suited for the work and road ahead. And it's also one of the reasons why we can't just rely on WHO or expect them to carry all of this water too. And I think you started to go there, Larry, with your own comments about other global health actors, right? You have a range of actors working not only in Geneva, but around the world. And I think it's important to acknowledge, the emergence of other important institutions and efforts. Africa CDC really came into the light during COVID, many thanks to our now ambassador, John Kangason, and of course that work is being continued by new leadership there. We have groups like CARPA in the Caribbean, which we point to, and other efforts in ASEAN that are emerging with their focus on the new sort of center for global health emergencies. And so it's really going to take all of us to contribute moving forward and understand what we're all bringing to the table so that we can leverage these what feel like increasingly limited resources, pandemic fund notwithstanding. Really glad we were able to stand that up. But I think we know from the calls, for proposals and the money in the pot, that there's still this disconnect between the need or demand and the dollars that can meet that very real gap. So that's, I think, our call to action is to ensure we recognize the role we each play in this space and come together to advance our collective agenda accordingly.
Yeah, I mean, I know we've got to get back to HHS.
It's fine. They'll give you they'll just walk in and take me.
So I'm just going to sum up and just talk about our appreciation of you and the work you do. I mean, I was just listening and reflecting on what you said so beautifully and passionately and eloquently. I wonder if our country, the world, understands how important this is. I mean, we're talking about nothing less than keeping us all healthy, keeping us safe. And even before COVID, I always thought that the major global narrative was one of inequity. And here we are now, 3-4 years post-COVID, and we haven't fixed it yet. It's really, really important, even to build back trust, that we don't leave people behind. And the work that you do and what your whole career and life is about, from your community work through your leadership at HHS and the US government, is just really inspiring. And I just want to end where I began, which is that we just don't thank you enough. So thank you for all that you do. Yes, we're not going to all agree with everything USG does,
For sure.
but you're in there trying for us, and we're enormously grateful. I'm enormously grateful to you for kind of blessing the O'Neill Institute with your presence. So thank you very much.
Thank you, everybody.